Now we will talk about how to manage the complications of chronic kidney disease. Complications like anemia and the mineral and bone disorders, which include hyperphosphatemia, secondary hyperparathyroidism, and active vitamin D deficiency. We will start with how to manage anemia in chronic kidney disease. Why anemia happens in patients with chronic kidney disease? As we said, one of the functions of kidney is to produce 90% of the hormone erythropoietin. Erythropoietin stimulates the red blood cells production in the bone marrow. Decreasing renal production of erythropoietin is the primary cause of anemia in patients with chronic kidney disease. So if we diagnose the patient with chronic kidney disease and we find the hemoglobin is less than 12 in females and 13 in males, we should make some investigations to define what is the cause of anemia. Mainly CBC, which include red blood cells, reticulocyte count, iron, and total iron binding capacity, ferritin, vitamin B12, cyanocobalamin, and the folate or folic acid level in the blood. If you found the patient has iron deficiency, we should start oral or parenteral iron therapy. If we found all are normal, but hemoglobin when it reach less than 10, we should start ESA. ESA is erythropoiesis stimulating agents like ebiotin or darbepoetin, like we will see in the next slide, plus iron therapy. And monitor the hemoglobin every 2 to 4 weeks. The goal to reach hemoglobin above 11. Here above 11. If we started with iron, and we should see if anemia corrected. If corrected, okay. If not corrected, we should start with erythropoiesis stimulating agent plus iron and monitor. Hemoglobin should increase by 1 gram in every 2 weeks. If we reach this goal, we can decrease the dose of erythropoiesis stimulating agent. If we found the hemoglobin not increase more than 1 in 4 weeks, we can increase the dose of erythropoiesis. So in summary, we should find if the patient has iron deficiency, we should give iron first. If it is corrected, okay. Not corrected, we should start with ESA plus iron. From the start, if the patient has iron normal but hemoglobin is less than 10, we should start erythropoietin directly with iron. If a patient increase normally, we can decrease the dose of erythropoietin. If not, we can increase the erythropoietin. Erythropoiesis stimulating agents, ESA, like ebiotin alpha or ebiotin beta or darbepoetin alpha. The most common adverse effects is increased blood pressure. So if the patient has high blood pressure, we should control first the blood pressure and the thromboembolism. So if patient has a stroke or MI, it is contraindicated to use erythrocyte stimulating agent in acute stages of these diseases. Iron supplements, we have oral and intravenous. Oral, like ferrous fumarate, ferrous sulfate, ferrous gluconate, or iron polysaccharide. The most common side effects are GIT intolerance, like especially constipation, dark stools. It should be taken on an empty stomach to avoid drug interactions and to stimulate absorption and increase absorption, and separate from calcium due to the interaction. IV, like iron sucrose and iodextran, use only if the patient is unable to tolerate oral iron or failure to achieve a target with iron, and monitor for hypersensitivity reactions. Some of these iron supplements should be tested before for allergy before continuing infusions. The second complication is hyperphosphatemia. How to treat hyperphosphatemia, high phosphate in blood, with phosphate binders. Phosphate binders prevent the phosphate in the diet to be absorbed, and it should be taken with meals. Examples of phosphate binders is calcium carbonate and the calcium acetate. They are first choice because they are the cheapest and the more convenient, but if the patient has hypercalcemia, we can use non-calcium containing phosphate binders like sevelamer and lanthanum. The third complication of chronic kidney disease is secondary hyperparathyroidism, and associated with this vitamin D, active vitamin D deficiency. What happens exactly? With impaired kidney function, the phosphorus excretion started to decrease. What happens? Parathyroid hormone BTH start to increase. Why? Because parathyroid hormone is responsible for excretion of phosphorus. So when phosphorus increase, the body feels that there is high phosphorus, we need to excrete them by kidney, so the parathyroid gland secretes parathyroid hormone. So the patient develop hyperphosphatemia, which lead to hyperparathyroidism. And parathyroid hormone, its action on bones is bone resorption. What is means by bone resorption? It takes calcium from bone to blood, and this lead to decreased bone mineral density, and lead to CKD, chronic kidney disease, mineral and bone disorder. So again, what happens with impaired kidney function? Decreased phosphorus, and when the phosphorus decrease, the parathyroid hormone increase. The parathyroid gland secretes more parathyroid hormone to get rid of phosphorus, but the problem is the kidney cannot excrete the phosphorus. And the other problem is parathyroid hormone start to make bone resorption. Also, hyperphosphatemia leads to hypocalcemia, decrease the calcium. How? Calcium and phosphate may form calcium phosphate stones or calcium phosphate precipitates in joints and arteries, which decrease the calcium in the blood. And with decreased vitamin D activation, as we said, kidney is responsible to convert the vitamin D to the active form. And vitamin D, what is the function of vitamin D? Increase the absorption of calcium from intestine. And if we don't have vitamin D, the calcium level decrease. So we have decreased the calcium and there is bone resorption. All of these lead to chronic kidney disease, mineral and bone disorder. How to treat this problem? First, normalize calcium level by giving calcium supplements. Any calcium supplements like calcium carbonate, calcium citrate. Second, prevent hyperphosphatemia. How? By diet, to decrease the phosphate in diet, and by phosphate binders. What is the examples of phosphate binders? Calcium containing. We can use calcium carbonate, for example, to treat hyperphosphatemia and to supplement with calcium. And if the patient in the late stages, we can use dialysis. Correct active vitamin D deficiency. We have a problem that vitamin D cannot be activated in the kidney because kidney is not functioning. So how to treat this problem? To give ready-made active vitamin D like alpha calcidol and the calcitriol. So we treat the vitamin D deficiency by giving active vitamin D forms. In late stages, if the patient has severe secondary hyperparathyroidism, we can give calcium mimetics. Calcium mimetics like cinacalcet. What is the mechanism of action of calcium mimetics? It acts like calcium. Here is the thyroid. This is the thyroid, and on thyroid we have the parathyroid gland. Parathyroid gland, which secrete parathyroid hormone. Parathyroid hormones stimulated by decrease in calcium level. In case of decreased calcium level, parathyroid hormone increase. Okay, and it acts by negative feedback mechanism. So when the calcium level increase, it goes to the parathyroid gland and stop the parathyroid hormone from secreting. So if we used calcium mimetics, something like calcium, it goes to parathyroid hormone and deceive it as if we have normal calcium and stop the parathyroid gland from secreting parathyroid hormone. This was a quick overview on renal diseases. I hope it will help you in your exam, and good luck for you, and see you soon inshallah.